Thank you very much. Thank you very much, Kelly. Real pleasure to be here today. RIWI, for those of you who don't know, stands for Real-Time Interactive Worldwide Intelligence. And what I'd like to do is just take you through a few slides here, about 15 slides, to talk about how to think about what diverse people think. And there's probably no better time to do this than now. The online data market today consists of what I call three categories of reporting on what people think. And most of what you hear in the news are attitudes derived from panel-based online polls or random digit dial calls from a very narrow slice of society who answer these polls. Answers to these polls are what I call settled convictions of habitual survey takers. On the left here are what are called inclinations data, which are likes and shares and tweets and retweets. This is often referred to as big data or early stage AI, from which you can supposedly divine intent. And right now, as we speak, big tech CEOs are gathering in Congress talking about misinformation and how that's absorbed. The reality is that inclinations data have proven very limited in value for targeted advertisers. And there's also extremely limited evidence to suggest, despite media commentary to the contrary, that misinformation we might share or see on social platforms actually drives our inclinations about complex policy topics on which we may change our minds. Sentiment is the only domain of online data collection which is dynamic and predictive, and you see that in the second box there in the continuum. In the field of finance, for example, it can produce what's called alpha, or beating the benchmark of the market. And in important public policy, it can also give us a clue into what people are concerned about now and into the future. The big challenge with sentiment, though, and at RIWI we specialize in sentiment data for clients like the US State Department, BofA Securities, hedge funds, and the United Nations and all nations of the world, is that it must be anonymous, very broad-based, and engage quiet voices, not just the loud and angry voices you hear about on social media. So we're often called at RIWI the real wisdom of the real online crowds. We invented and patented a global technology platform in the 2000s, originally used by the Ontario Ministry of Health, to understand where in the world people were more or less educated about the H1N1 vaccine, the measles, mumps, and rubella vaccine after the retraction of the fraudulent Wakefield study, flu hygiene matters, and a variety of pandemic-related issues. Our machine learning invention leverages what's called the domain name system of the internet, such that people in any country on any device randomly stumble into RIWI questions or ad tests as they manually hit on a broken link in a news article or blog, or type in a lapsed website into the URL web address bar. And we reflect the opinions of people who answer our questions and represent a mirror of the internet using public in that country or region of interest. So very unlike email access panels, these random survey sites do not register spam warnings since they are real registered web domains and can bear the logo of RIWI or our client like Harvard University. And this gets us anywhere from 40 to 80% of people anywhere around the world who have not answered a survey or ad test of any other kind in the past month or ever, and usually from people who do not post online either. So for sensitive, dynamic, and dynamically complex policies, like vaccine hesitancy or like changing attitudes to LGBTQ issues in every country of the world for which we are the largest officially recognized data collector, or changing support for violent extremism, the RIWI approach proves remarkably reliable. And this is why we work with universities like Australian National University, Harvard, and Oxford to carefully compare the same types of congruent, sensitive topic data in different countries. So here's the problem. If you don't listen to these quiet voices, as happened in the 2016 US election and a wide number of significant global macro events that RIWI has predicted, you wind up with the wrong prediction. you're essentially basing your prediction on those settled convictions from that narrow slice of online panels I talked about. And the reality is that on most divisive issues, most people's views are changeable. At RIWI, we saw the momentum shift from Democrats to Republicans over the 21 days before the 2016 US election. And the US election work for which we worked for a UK hedge fund, it was actually one of the most statistically clear binary events for which we've been engaged to predict in the past 4 or 5 years. That being said, this time around, things are a little blurrier. You see here in the national data, just since June 1st, we can see that things nationally have gotten a lot closer than at the start of the year in terms of people's forecasts at the state level. Now, we do know, of course, that it is about battleground states and key Senate races. But that being said, and as a pretext and context for this discussion, we are concerned at RIWI that traditional pollsters may make the same mistakes they made last time in failing to engage this very wide audience of quiet voices. So bringing it to the topic of vaccine sentiment, we've been in the business of tracking sentiment data on vaccine uptake during pandemic since our inception as a company. This slide shows our early graph data in 2010. What we saw here is that even after Health Canada, our equivalent to FDA, approved the H1N1 vaccine, people's concerns did not decline about the vaccine. And this may be, I feel, a harbinger of what we may see in parts of the world in the future with the COVID vaccine if it comes to fruition and even if it's safe and proven effective. So just because concerns about the vaccine are pronounced now, it's no reason to think that these concerns will decline even after safety and efficacy are clear. And this scenario is very concerning, not just for the adherence to vaccinations for COVID, but concerning if vaccine hesitancy leads to hesitancy surrounding routine childhood vaccinations. So we've been asking tens of thousands of people across 11 countries about whether they would take the COVID-19 vaccine if it were available and mandatory by law. We wanted to see not only what uptake rates would be in specific locations in North America, but in varied countries across the globe at different stages of the pandemic. Over the duration of data collection thus far, we found that these numbers have stayed fairly consistent. Brazil, interestingly, has the lowest vaccine hesitancy on our spectrum, despite research elsewhere reporting that about 9 out of 10 Brazilians report frequently hearing and consuming misinformation online. US, Canada, Nigeria, and India have very similar rates of vaccine hesitancy, despite very different political and medical climates. I am concerned about Russia for a wide variety of reasons. In particular, there are reports of extreme vaccine resistance beyond our data and intense distrust of public health authorities. China is different and also interesting, since we see through our other data very high sustained rates of support for public health institutions. But why do we see such high vaccine resistance? So thinking about China, we see that vaccine hesitancy is actually based on an amalgam of complex factors we're learning about. And often very thoughtful people are influenced by medical history and a wide range of other variables in arriving thoughtfully at their so-called hesitancy. I do not like the term vaccine hesitancy. It's what we land on today, but it suggests erroneously that people who are hesitant or resistant sort of always have a knowledge deficit, when that is not necessarily the case. In China in 2018, the company Changsheng recalled its vaccine for rabies and was fined for selling ineffective vaccines to inoculate children against diphtheria, whooping cough, and tetanus. So we cannot presume that those who are vaccine hesitant are a class of homogeneous people in any country or region. History, in fact, suggests that vaccine hesitancy is hardly a new phenomenon and long predates the rise of the commercial internet and certainly online misinformation. Across the United States, the RIWI data show a higher rate of vaccine hesitancy than most traditional polls, both in the United States and Canada, which put it anywhere from 13 to 30%. largely, in my opinion, because those traditional polls are based on the type of settled convictions data from that narrow slice of people who answer online panels I noted earlier. And despite the political and social dynamism across the United States, we don't really see a huge variation regionally. Though we see that there is less vaccine hesitancy in the Northeast, it's not a significant difference. Just like the disease is not a red blue state phenomenon, hesitancy, in our view, does not vary as between blue and red states. A very high percentage of all respondents in China would not take a COVID-19 vaccine if it were mandatory, but we see that this has been affected somewhat by the COVID-19 experience. Desire for uptake of a mandated vaccine is highest in the central region where COVID-19 has been most rampant. Here we see, we used the travel advisory in US states about 14-day quarantine as a proxy for infection rate intensity in the US. If you're traveling from a state with quarantine, it's expected that you quarantine for 14 days after traveling. So where we saw a difference in China between the region that was worst hit, there is no difference in vaccine hesitancy as among states with high infection rates and those with lower. Again, in the United States, vaccine hesitancy on our meter appears to be very entrenched and widespread. So, like many studies of vaccine hesitancy, we do find that education level is linked to COVID-19 vaccine hesitancy. But note again that we should not overhype lower levels of formal education as a driver or cause of vaccine hesitancy. The sentiment is very widely spread. Now, what we do see is that those with a lower confidence in health officials' ability to educate and protect the public do show higher vaccine hesitancy. And this tells us that public policy may be more about shoring up trust in public health officials rather than telling people what to do vis-a-vis the vaccine in a top-down manner, but not always, as we know from China. So different populations in different countries may need a different kind of authentic dialogue to bring diverse publics along. And Nigeria, like the United States, we see higher trust in public health officials translates into higher support for vaccination. And we've actually seen the same trend in Nigeria with other diseases we've looked at in conjunction with Médecins Sans Frontières and others, looking at Ebola and Zika, where local religious leaders historically have been very engaged in broadcasting trust in local health officials. So this suggests to me one consistent message of vaccine hesitancy, which may transcend different diseases and vaccines over time. What we may need to emphasize is not to fight vaccine hesitancy or promote vaccine optimism, but rather engage in thoughtful, respectful dialogue that engages different subpopulations in ways that shore up trust in local public health officials, whose trust levels may depart dramatically from the political leadership. And this is important for what I call the long tail of policy success once we do, as we hope, have an effective, safe vaccine in widespread distribution. So thank you very much, and I turn it over to you, Kelli, and we'll begin the conversation. Thank you.
Fantastic. That's fascinating data, Neil, to share with the group. I want to bring in Jim to talk a little bit about, from his perspective, the endowed chair of public health at Emory University, the perspective on, with respect to public health in terms of inclination, sentiment, and attitudes, and what this data says to you. So Jim, I'm going to turn it over to you. I think you're on mute.
There we go. I've unmuted. I think my Zoom skills should have been more highly evolved at this point. Thanks so much, Kelli and Neil, for having me. Let me start my comments by telling you about a slide that I use in a lot of my talks and our work, and it's a slide of Bill Gates talking to a Wall Street Journal reporter in 2012 after having met the Sultan of Sokoto in northern Nigeria. And he was fascinated about how resistance to polio vaccination in northern Nigeria had been turned around in exactly the ways that you described, Neil. So that's really one of the points of, and what he said to the Wall Street Journal journalist was that that science and technology can take us so far, but the human piece is the ultimate test. So I think that that point is really a point of departure for me in looking at your findings, that really what they suggest broadly, I think, are all kinds of just complexities about the human experiences that we're trying to reach into, and from a public health perspective, trying to have some positive influence on. When I first started to talk to you, Neil, about some of these findings, I had just been reading Cass Sunstein's book, How Change Happens. And he talks about this idea about sort of private positions. And he has this notion of change has to change, people have to cross these, what he calls thresholds for preference falsification. So you have to have some notion that you alluded to really nicely in terms of sentiment and inclinations. Something has to shift them a bit for change to happen. And, I'm particularly interested in the way that vaccines, broadly speaking, but intensively so right now with COVID, are caught up in this very complex political and social narrative. And, I think about this analogy, if you'll tolerate the analogy, to vaccinology of adjuvants. So we know a lot about how the packaging of vaccines biologically has an enormous impact on their immunogenicity, on the way that they actually elicit immune response. And I think that there's a real analogy on the social side. I think the conversation about vaccines are packaged in these very complex social narratives. And I think they do function to some degrees in the same way that adjuvants do. They can really have an important bearing on the kind of traction that certain messages get, or the overall idea of vaccination gets. And so I think what your findings are kind of offering up for someone like me is that we're really grossly misunderestimating the potential here for this idea like hesitancy, or some phenomenon like collective hesitancy. I think we tend to think about it as a much lesser challenge than what you've laid out. And I think your findings just at a face level are quite staggering when you look at those numbers, especially given the background about your predictive experiences with RIWI. And so part of it is, how do we, as public health folks, how do we start to think about engaging with the dynamics that your findings are suggesting? And one of the things I think that you mentioned was this idea of trust. We place a lot of currency in the concept of trust in public health. But I always like to challenge people to say, trust isn't really what matters to people. Trust is sort of a description of a cross-sectional state of affairs in a relationship. What matters to people is trustworthiness, whether or not it makes sense for me to place my trust in you with some important life interest as an agent that's going to be protective of that interest. And here, I think, is where we really get into these different types of narratives, and how difficult it's going to be, to go back to Sunstein's ideas, is to sort of do some preference falsification, because I don't think it's going to be about the communication of simple messages. I think that for too long in public health, we have just assumed that our work is about filling knowledge deficits. And I think that the way you set up your findings, Neil, just make it really, really clear that it's much, much more complex socially than that. And so really, I think what you're giving us is some traction, some starting points for where we get points of entry into those conversations, to listen, to understand better the influence of some of these narratives, the influence of where people are still shifting their notions towards more settled attitudes. So maybe I'll leave it there for now and just kind of jump into the conversation. I guess the one thing I did want to ask, though, Neil, and maybe this is another segue into the conversation, is I was also interested in your framing of the question that you're reporting out on here today in terms of mandated vaccination. because, you know, we've seen, certainly in the United States, in National Immunization Program in the United States, some incredible variability on people claiming exceptions, and some frank hostility in many cases to anything at all that looks like a government mandated type of intervention. So I'd just be really curious to hear more about that framing.
Yeah, thank you, Jim. There's a lot to consider. Very, very thoughtful. You know, in the framing of the question, we did include the word mandatory, largely because we wanted to talk about the big elephant in the room, that there may, in fact, you know, as we may, you know, expect if we think sort of deductively as opposed to inductively, and think, okay, getting those vaccines into arms at a certain point, there may in fact be some form of mandatory requirements, whether those are official or in the form of incentives, disincentives in some shape or another. And that word mandatory, of course, can carry with it different nuances and interpretations in different parts of the world. So we wanted to be congruent in our comparison, and using different language would yield different responses. And yes, what we do find on the data just generally is that when you do include that word mandatory, it creeps up, certainly in the US context, in terms of resistance. I was struck by two things you said. One, about the sort of constituent parts of trust and in fact, trustworthiness. I'm increasingly drawn into the business scholarship, which talks about authentic leadership, authentic trust, which may not necessarily be about consistency in terms of bringing people along, but maybe about being forthcoming and saying where you've messed up, right? And we do know that does yield a sort of engagement from the public. I was also struck when you talked about process in public health, and I'm reminded of what some things we've learned in other areas of public health, like obesity. We know very, very clearly, right, that these top-down shaming narratives around obesity, telling people, dictating, you got to do this, that, and the other to get in shape. We know that doesn't work. It can lead to shaming and in fact have the reverse effect. So I don't know if that leads you to any other insights, or Kelli, you want to jump in with another question? Thank you.
Well, actually, Neil, if I could pick up on those before Kelli throws in another question. So on the first one, you know, I think where I see a real point of connection, and again, where I see, let's call it a underperformance in public health, is in how we think about accountabilities of public health to the public or to various publics. And, you know, the notion of authentic leadership, I think, is partly, as you said, about just being able to say, look, we're doing our best, but we are accountable to you as well for the things that we're not doing as well and trying to improve. And there, I think that there hasn't been anywhere near the acknowledgement I think that's necessary in public health around vaccination, that we have really been using kind of shaming approaches. We've been treating it as a knowledge deficit, and we're essentially shaming people for not having the right types of knowledge. But I always say, if you think, let's say you're a young mom and you have a couple of kids, let's say you're actually really smart, and let's say you have some notion of herd immunity, and let's say you sort of think, well, you know, I know rates of bad consequences from vaccination are very low overall, but they actually happen. And maybe I'll do the gambit here, and I'll be a free rider. You know, maybe I'll just make a conscious decision to ride off the herd immunity without putting my own individual kids at risk. And when you're living in a society like we're living in here in the United States, which is so heavily skewed toward individualism, that decision to me seems perfectly reasonable, even though it's antithetical to the core kind of mission of public health. And just on your specific point about shame, there was this guy years ago I can't remember his name, I think it was Neil Seeman, who wrote this really terrific book called Obesity and the Limits of Shame. And one of the things that, that really struck me about that narrative that you laid out so nicely in that book, Neil, is that we actually know an awful lot about the biology, the underlying complexity of the biology and physiology that contributes to obesity. And we haven't done a good enough job, I think, in public health in bringing those insights to bear on the way that we think about the narrative about obesity and communications and support for people around what we know about that complexity. And again, I think there's a real analog there in terms of the social complexity that underlies vaccine hesitancy. I don't think we're engaging with it effectively in public health. And so I think your analogy on obesity is a really fascinating one for a number of reasons, but I think that notion of the underestimation of the social complexity here is really, as I said before about your slides, it's a super point of entry to move this, this dialogue forward, I think, in public health.
So I'll jump in here, considering the social complexity, because I think that's a really important element. We have a question from one of our attendees who's asked, based on the findings, what advice would you give Fauci in terms of vaccination policy?
Thank you. So far be it from me to be directive on this, but I may bring it back to a point Jim raises and indirectly suggest a beginning point to the answer to that. Jim and I actually first met each other and wrote our first paper on a relatively simple ethical challenge, right? At the time, very difficult. It was do not resuscitate policies in hospitals. And we essentially surveyed, right? We surveyed hospitals, Jim, and we determined binary response. Okay, did they have a policy? Did they have a process in place in order to engage the people in a discussion around do not resuscitate disorders? And we found that, Jim, I think, as a worthwhile point of entry. And so maybe to answer this individual's question, I would suggest that understanding process may be important, that there may be a process piece of the dilemma that can start us on a dialogue. Jim, do you have any, maybe you can fill in the pieces of this puzzle?
Well, I think we've talked in the past, Neil, about how simplistic that project felt. We used a sampling frame of every public hospital in Canada. So there were about 1,100, I think, or something. And we managed to get most of them. And we just went and, do you have a policy? And, and it seemed simplistic. But of course, now in retrospect, what it did was it really established quite a useful platform. And to tie it back to a comment I made about your findings a minute ago, Neil, I think one of the things that we learned from that experience too was that there were a lot of hospitals that didn't have policies, and I think you remember a lot of those conversations we had, even when they started to find out, even before the paper was published. People, the response was, "Oh, that's not good. We better get a policy." So I think there was something about laying the problem out, or the context out for people. And here I'll go back to my earlier point. When when you read the New York Times or even the Economist, or like the numbers that I've been seeing are in the mid-20s, high 20s, maybe low 30s potential for vaccine hesitancy. And I would say that your data are kind of a warning shot. Hey, don't be complacent about the numbers that you're seeing for all of the reasons that you laid out so nicely in terms of the real expertise that RIWI brings. So I think that what you do is you lay out, even if it's just getting people's attention about the potential scale of the phenomenon that looks like it's really different from the numbers that we've been sort of thinking about so far. I think just that in itself, Neil, will have an incredibly sobering effect and should have a real focusing effect, I think, on public health.
So another question from the audience. Have you collected qualitative views, open-ended views, that is, on such as to why people have low degree of confidence in public health officials in different countries? Why people are not interested to take the vaccine despite so much infection and death that we've all been made aware of? And an additional part of that is, how about in Canada?
Thank you, Kelly. So the short answer is no. On this instrument, we have not collected qualitative, sort of unstructured responses on the reasons why, the rationale as to why. We probably should, and this is sort of the first lay of the land. We like at RIWI to just sort of sequence things in terms of initiatives. We have done a lot of work, and we've gone public with this in respect of mental health and the implications, again, for mental health globally, and stigma surrounding that. And that's where we've dug into more qualitative elements. But on this element, no, we have not, and it should be an area of investigation. Thank you.
And Neil, if I could, we haven't done any qualitative interviewing on this topic either, but we've done some work, I think, that's kind of relevant. And I just see from the participants, I think Brianna Wadnick from our team is on the call, and Brianna led a really, really nice study in some of our work in Haiti on lymphatic filariasis elimination. And it was really about hesitancy to participate in mass drug administration. So vaccine wasn't the technology in this case, it was more drug administration. What we found in that study, which is published in PLOS Neglected Tropical Diseases, if anyone's interested, but what we found in that study was that the messages, the communications, the framing that was coming from the Ministry of Health, from the program itself, had to compete with all kinds of other narratives that were out there. And this is kind of where I was drawing from in some of my earlier comments, that it's never as simple as delivering up a message that will then resolve the underlying uncertainty. It's about this kind of battleground of competing narratives that function, as we described in that paper, as kind of mediating factors in the way that the public health messages get delivered. So I think that's just one of the components that you're likely to see if you dived into deeper interviews with people, which I think is just a really terrific idea. But it's about just this, back to this complexity that I was describing before, of that makes it difficult for people to resolve into settled attitudes. You know, they're actually juggling a lot of different ideas to try to resolve into settled attitudes.
Thanks, Jim. That was really helpful. And kind of following up on that, you know, it's an interesting question because it's like painting a picture, right? There are competing elements that all come together and really bring opinion to an individual. So thinking about that, what gaps do we need to address in order to plan or adjust critical public policy and to make public health and business decisions so we can move forward?
Well, Jim and Kelly, thank you. I mean, I think one thing we need to do is get rid of the conceit that we can clean up social media. And further to that, that cleaning up social media ipso facto will resolve to everyone being properly educated. You know, we're having a difficult time around the world, you know, understanding foundational truths. And the idea fundamentally that I'd like to suggest is that sort of once these ideas and misinformation are propagated on social media, it's kind of too late. So I think we need to sort of think about things in a as valuable as technology may be to collecting these data, making people aware, making them engaged, there are limits. We need to be, if there's been any problem, one problem that transcends every other problem with respect to this this pandemic is our lack of humility with respect to the pandemic, and we need to be humble with respect to the power of technology. Okay, and so that's one thing I would issue as a caution, and maybe Jim, you can come in on the policy side. Thank you.
Yeah, well, I mean, I agree with you, Neil. What was going through my mind when you were making your comment there was, we know that knowledge is socially constructed. And in this case, I think that the social construction of knowledge can be a real problem because of a lot of these competing influences. And a lot of them are not, they don't have beneficent intent, a lot of the competing narratives. They're really meant to forge or to force alignment with political ideology, or to kind of constrain people in various ways within a group. And this goes again back to Sunstein's notion of false preference falsification, which means you have to step outside, you have to be an outlier in your social group. So we know that social construction of knowledge is a problem in this case. But I would say that maybe the magic of this is that social construction of knowledge is almost certainly also the solution. And it's where we have not been, again, we haven't done a good job. I mean, I'm like a broken record with this, but I think we use terms like engagement so flippantly that, we don't really think carefully about what they really require. So I think, imagine a context where you could bring people of different perspectives together, maybe around your findings. And rather than say, look how bad you are, but just to say, what do you see here in these findings? How do they relate to where you are in trying to arrive at your own personal position on this, or your own more settled attitude on it? Neil, you and I are involved in another project to try to do something very similar to that at the moment. But I think that notion of leveraging our understanding of the social construction of knowledge in this case, and infusing that with the kind of humility that we haven't demonstrated effectively, it hasn't been part of our offering of trustworthiness. I think that could be at least fascinating and potentially useful.
Neil, did you have a follow-up on that?
No, thank you. I'll invite you to jump in. Thanks.
Okay. Well, we'll move on to the next question from our audience members, and it's what may be important in trying to persuade individuals to do more listening instead of talking? And what do the speaker think about that process of really being able to listen more, having public policy experts and those in circles of influence listen more and talk less?
Thank you. Jim, I'm gonna invite you to jump in on this.
Sure.
This is your
yeah.
Anyway, thank you.
Well, I think it's fundamentally, first of all, it's a great question, but I think it's also fundamentally a question about design. And it's not the way we tend to think about things in public health. We tend to think about p-values and look at how staggering the findings are. But in our program, we're starting to do more explicit work around knowledge co-production. And I've been reading about this for a long time. People have been talking about that kind of stuff for like 50 years. It's just that we haven't really done it. But as we start getting into our own work and apply it, you realize that the critical factor is whether or not you can design the appropriate contexts to actually listen to people in ways that they find convincing. It all sounds simple, or it feels simple when you're musing it around in your head, but it's actually not easy to do. But imagine the difference between pulling a bunch of people in who were vaccine hesitant to, I agree, it's not a great term, and saying to them, what we're trying to accomplish in public health is to protect your children and to protect you. And what we'd like to do now is have you help us design our approaches. Clearly, there are issues that we're not getting right, and we'd like to understand better what those issues are. But we'd also, beyond that, we'd actually like to elicit your ideas about how we ought to do it. What's not working, what might work? Do you have suggestions? Do you have insights from your own experience that might function as, design parameters, as we call them, that might give us some better ideas about how to pursue and structure those very dialogues that we think might be effective.
Thank you, Jim. I mean, right on. I mean, that it does come down to authentic leadership, and what we're very successful to smoking, right? As top-down counter-marketing, right? When the Surgeon General came out, explained very clearly, people then responded in kind. We don't have that same luxury today, and
yeah.
nor does it lend itself to that level of simple communication.
And to that point too, Neil, I'm not advocating for a second that public health should stop trying to reinforce ideas that vaccines are safe and effective. What we need to grapple more with is those very real, though rare, parts of vaccination history where things go badly. And to your point about authentic leadership that you made before that I really liked, part of that authentic leadership is to be able to, sit in a room with people who are hesitant and say, we understand that bad things happen. And we understand that if a child dies, if your child dies, the consequences for you are life-shattering. And the consequences for public health are more statistical. And we have to figure out ways of reconciling those experiences in some form of dialogue. One of the things we've learned in our work, Neil, on stakeholder engagement, and this is about looking at people who have been very opposed, for example, to the introduction of new genetically modified technologies. And what's really fascinating in some of the case studies that we've done is that at the end of the day, people actually don't care anywhere near as much about the technologies themselves as we thought they did at the start, but they care 500 times more that they were not acknowledged as people who may have an interest in those technologies. So they weren't given any standing as having legitimate interests in that. And I think the same is here. Someone who's concerned about those vaccine side effects, they're just easily dismissed. And we don't do a good enough job of just even acknowledging them at that human level as someone with a sensible and legitimate concern, even if it's a bit of an outlier in the way we think statistically about vaccination safety.
Thank you, Jim. And moving on to another question from the audience, it seems political ideology and lack of trust, belief in alternative facts and conspiracy theories, et cetera, seem to be much larger of a problem in the United States than in the EU or in Canada. And do you have any idea how we account for that discrepancy?
Thank you, Kelli. I think you may have gone on mute, but and the question around vaccine misinformation being more pronounced in the United States. We're actually finding that it's very pronounced around the world. It gets more media attention in the United States, certainly, but it is quite international, certainly in Russia, certainly in Brazil, which does invest a great deal of faith in the necessity to get a vaccine. What to do about it? We've talked in the past in papers we've written about online counter-marketing, but in a manner which is engaged so that we avoid what's called white hat bias. So we get participants in these dialogues who engage in the dialogue, but do not represent sort of the white hat bias of government stakeholders. Jim, do you have any reflections on that?
Yeah, well, I mean, I would just go back to your data you know, I'm a Canadian, and I mean, my team will tell you, like, I'm a real ferocious Canadian, but I'm living here in the United States by my own will. But I think that when we see things going badly in certain ways, there's this real yearning that we have to imagine that things are better in Canada. And I would say that one of the most valuable things about your findings, again, just at this first, I know there's a lot more beneath the iceberg tip, but just at this kind of first iteration level is don't get too complacent. Don't be too quick to accept your starting premise that you articulated so nicely in this question, Zain, that if we just accept it at face value without more scrutiny, then I think we run the risk that we miss signals that your data are just really helping us to see.
And in that context, Jim, we have another question related to what can other countries learn from each other as we start looking at the data and start seeing where other countries are looking at this issue as well? Are there learnings that can be shared?
Yeah, Neil, I mean, I think you guys are closer to that one. I'm happy to chime in, but maybe take a stab at that first.
Oh, thank you. I mean, I would step back a little bit and say that there's something foundational about that question, which is so lovely to hear, right? So again, one of our missteps around the world with respect to this pandemic has been a lack of yearning to learn from other countries, right? So in particular, what can we learn from China? What can we learn from the Chinese people, irrespective of what we may think of the Chinese Communist Party or what's coming out of Beijing officially, is that, you know, that, for example, we know that there is a great, you know, in the field of mental health, there's a very heavy burden from a mental health perspective and anxiety among sort of people in the 45 to 64-year-old age group who have to take care of their parents as reopening occurs. So, you know, one of the things I'm very struck by is understanding, for example, as we march forward with different stages of reopening, what's happened and what can we learn just on the tip with respect to anxiety. So I'm very heartened by the mere fact that we're asking that question right now. Jim?
Yeah, I mean, I think that's exactly right. And you know, the other part, I think, to the question, I agree with you, that these are great questions. The other part of the question, I think, that resonates with me and the kind of work that we do, I mean, we like to just go around, talk to people and say, hey, like, how are things working for you? And what we find is that the human interactions in complex systems are ultimately what drive success and failure. They're really the core of how things really work. But they are absolutely still not privileged as high level academic spaces. You know, they're whatever people say, they're just not. They don't have the same currency as really big, you know, as AI, as like big data stuff. Like they're still seen as kind of qualitative, as if qualitative somehow is a lesser way of interrogating deep social kind of problems. So I think that the question touches on that aspect as well. We don't know enough about the lessons because they're not privileged academically, even for people to share. I actually think we have amazing lessons in a lot of the journalism that's out there, right? I think investigative journalists should get much, much higher currency or higher status compared to academics. I mean, I read really well done investigative journalisms, and I'm just awed and humbled by them as an academic. I mean, because I think that they're so intelligent and they get you into places that are so hard to reach. So I think part of it is just like what we privilege in terms of stories that are worth sharing. And yeah.
Okay, and it looks like we have a time for one more question here. So I want to share the last question from our audience. COVID has seriously hit hard. Millions of people in Asia and South Asia. Millions are in poverty. Children and marriage has already increased. Children are out of school. There's a food crisis and so on. Many things to handle. Is RIWI considering research on financial and mental impact due to COVID?
Yes, so we've explored this quite considerably, and we're doing more. The mental health burden associated with COVID is extraordinary, and it's around the world in different shapes and forms. So we are measuring this in many countries around the world. We've recently released reports with the UN World Food Program in a number of countries, looking at just the deep grief associated with financial subsistence as it relates to COVID. I mean, this really, I mean, you know, I'm always reminded that pandemic comes from the Greek pandemos. It's a global challenge, and we can't think of these millions of suffering individuals in different parts of the world as somehow separable from our individual challenges. Again, that's sort of smugness that Jim may have been referring to. Even if we may be protected for a moment in time, we need to be extremely sensitive to those challenges around the world, not just to help those individuals, but also to understand what may in fact happen to us. Thank you.
Yeah, and if I could add to Khalid's question, you know, and not to embarrass Neil and RIWI, but Neil's been extremely generous as well, even in our collaboration at Emory University, with offering up some really interesting data for a couple of our students from China. And actually Lan Yuzhang is in the participant list here as well. And they're doing some really interesting explorations of you know, the kinds of things that we can learn in comparative analyses of these data. We're trying to get our minds around how to use these data effectively, because they're incredibly rich and powerful, kind of beyond our imagining at the start. And so, but that's exactly the focus, is on anxiety and some of those deeper mental health issues, and the context, and try to contextualize them. So just a call out for an appreciation from us for that, because it's been incredibly helpful.
And thank you guys. This has been so insightful. I want to invite both Neil and Jim to kind of give a last statement or summary that you want to leave our audience with today before we end.
Well, Kelli, I want to just say thank you to the participants for engaging in what I think this is, which is a difficult conversation to have around vaccine hesitancy, and it's the type of difficult conversation that we need to have if we're going to engage in authentic leadership and really meaningful, engaged dialogue. So I just wanted to thank you for that.
And I'll just say just how grateful I am to be involved in the conversation, and how innovative and important I think what Neil and the RIWI team are doing here. And I think for me, it really represents a different kind of challenge for public health about how to interact with these complex phenomena, and how to keep this kind of humility as we kind of learn from the findings that RIWI was putting out, and see where they direct us to try to improve. So I'm just really grateful to be involved, and thanks so much for the opportunity.
And Neil, if our participants want to find out more information or see more details on the information presented today, where can they find that?
Thank you, Kelli. So certainly you can visit our website at riwi.com to get a universe of case studies on a wide variety of COVID-related data. We're going to be serializing these reports, and there's a whole range of future publications, but we will be in a position to share these slides with whomever expresses interest by going to our website.
Wonderful. And with that, I just want to say thank you to both our outstanding panelists. Neil and Jim, thank you for such an outstanding discussion, and thanks to those who joined us today. We will have a video of this this event available, and so we will make sure that we can send that out to all the participants that you can share with others that you think might be interested in this topic. So thank you again for a wonderful conversation.